Perfect. Looks great.
Okay, great. Thanks so much. So first, I just want to take a moment to thank my colleagues at the Hepatitis B Foundation, Dr. Fenkel, Catherine, and others on the organizing team. I'm really thrilled to have the opportunity to hopefully share a few thoughts that I think that will be familiar to those who are already engaged in the management of patient hepatitis B. I think that so perhaps in the future sessions, we can go into a little more depth about some specific topics I think that are often less recognized. And I'll focus on today is some initial concepts regarding the epidemiology, screening, diagnosis, and management. But I will touch very briefly on some of the comorbidities that are seen in patients with hepatitis B that I think do require careful attention. So I think that for those who are already familiar, I think that we all can agree that hepatitis B remains highly prevalent globally and within the United States. This map is familiar to most of you probably, that helps to articulate the countries that appear to have the greatest burden of chronic hepatitis B globally, as reflected in the orange color, where the prevalence at the country level is estimated at greater than 8%. The yellow countries, those in the intermediate prevalence range, 2 to 8%, and then in the green, less than 2%. And this is important to highlight because this helps to identify the countries of origin seen in our patients that we care for who are at the highest risk of having hepatitis B exposure, number one, and number two, having ongoing chronic infection. Globally, we estimate up to about 4% have been infected with hepatitis B, and a small fraction of which have been diagnosed with infection. Remember, I think this is a silent disease. So I do want to highlight that in the United States, there are a number of studies that have used epidemiologic surveys, others that have used trying to extrapolate from foreign-born persons using country of origin prevalence rates to try to get a sense of what is the true prevalence of hepatitis B in the United States. The epidemiologic studies generally have a tendency to underestimate hepatitis B, largely because some of the highest risk populations may be underrepresented in those surveys, most notably NHANES. But however, they do provide rich data that can be useful for identifying the prevalence rates based on specific groups. Overall, the epidemiologic surveys suggest a prevalence of around 0.3 to 0.4%, where the highest risk is seen in Asians and non-Hispanic Blacks, which in the case of non-Hispanic Blacks, about twofold the prevalence of the general population, and an Asian population up to 8 to 10 times the rate of the general population. Now, furthermore, if you look at foreign-born versus U.S.-born individuals, we do also see a discrepancy. In U.S.-born persons, we do see a higher prevalence in both Asians and non-Hispanic Blacks. And of course, in foreign-born persons, especially from endemic regions, we do see that, again, we see higher rates of hepatitis B, like both in non-Hispanic Blacks, about twofold prevalence, and the Asians over 10 times the prevalence compared to the general population. Imitation studies that look at foreign-born persons estimate that the burden may be as high as 2.2 million persons. And based on a consensus effort sponsored by the Chronic Liver Disease Foundation, there was an estimate consensus of around 1.6 million persons. However, the range could be as high as 2.5 million persons in the US. And then the key message here is that there remains an ongoing burden of hepatitis B, much of which remains undiagnosed. And that's where all of us collectively have a role in trying to do our part for broadening the group of patients for whom screening should be considered, diagnosing patients, linking to care, and offering appropriate management of those patients. So I want to briefly highlight, and I'll try to avoid going into too much detail in interest of time, but just to remind ourselves regarding the screening recommendations of the CDC from the original 2008 document and the AASLD from the 2018 document. I'll come back to the updates in a couple slides. But I think that on the left are those groups for whom are deemed to be high risk for hepatitis B, where screening is strongly recommended. This is, again, individuals born in high prevalence or intermediate prevalence countries in the yellow and orange color. Children of parents born in high prevalence countries, 8% or higher. Injection drug users in the past or present, MSM population, HIV co-infected, household or sexual contacts of Hep B infected individuals. Any person undergoing immunosuppressive drug therapy should be screened. The next one is one that we often under-recognize are individuals with diabetes type 2, anyone with abnormal liver enzymes, pregnant women, infants born to infected mothers, all blood organ tissue donors, and hemodialysis patients. Now, this is a very long laundry list, and I would highlight that the ASLD is actually is inclusive of each of these risk factors, in addition to those highlighted on the right. And this is inclusive of those who are healthcare, public safety workers, many of us on this call, travelers to countries high intermediate prevalence, etc. The one group that I think is often missed is the one at the far lower right, which are inmates of correctional facilities, who I think we agree are confirmed to be at higher risk compared to the general population. Now, I think that what we want to move towards, and I think is highlighted by many who've commented earlier, is that risk factor-based screening is difficult because it requires time for us as clinicians or advocates to be able to ask these challenging questions. It is awkward to ask these questions. We often see that when a trainee looks at social history of a history and exam, they usually ask about tobacco use and alcohol use, but asking about your country of origin, whether they reject drugs, their sexual practices, it becomes much more challenging to identify these risk factors. And I think that therefore there is a strong move and advocacy to move from risk factor-based screening to universal screening, which we'll come back to in a moment. Now, there was an opportunity by the U.S. Preventive Task Force in 2020 in their updated screening guidance to make a shift from a risk factor-based to universal screening. That did not happen, but they did again reaffirm their prior guidance in 2020 for screening of at-risk groups, including the persons born in intermediate or high prevalence countries, U.S.-born persons not vaccinated as infants, where their parents are born in high prevalence countries, those with HIV co-infection, injection drug use, MSM, and contacts of persons with hepatitis B. Unfortunately, I think this is, in my view, a lost opportunity to really shift from a risk factor-based screening to universal screening mode. However, many of you are very familiar that the CDC last April published their public guidance document for which they have articulated a plan to expand screening to all U.S. adults aged 14 or older, plus individuals who are pregnant regardless of age, and furthermore, enhanced screening or testing of those who are risk factors, particularly if there's ongoing risk. So in other words, for the first bullet here, this is a one-time screening in all adults age 18 or older, but then episodic additional screening based on pregnancy and other ongoing risk factors. So I'll transition briefly to the why question. Why do we care about hepatitis B? Hepatitis B is like any other chronic liver disease in the sense that it is associated with chronic inflammation of the liver, which in turn can lead to progressive fibrosis and scarring of the liver, which may have the endpoint of cirrhosis, liver failure, and liver cancer. What is unique to hepatitis B, of course, is that unlike other chronic liver conditions, it has immediate and direct oncogenic potential, meaning that it can be associated with liver cancer at any stage of disease, regardless of the presence of cirrhosis. And this is fairly unique to hepatitis B among liver diseases. And as such, it is responsible for liver cancer as the #1 etiology globally. And obviously, this is directly tied to HBV, particularly in high prevalence regions of the world, and remains one of the leading causes of liver cancer, even here in the United States. The risk factors for disease progression are well known at this point in terms of progression to liver endpoints, cirrhosis, liver failure, and liver cancer. This is far beyond the scope of today's brief discussion, but I think that you'll recognize that there are many virologic factors. There's disease factors related to liver, demographic factors based on age, ethnicity, and gender, as well as other environmental factors that may contribute to risk of these endpoints, such as alcohol and tobacco. But I think that most of us would agree that the virus level, or HBV DNA, is likely one of the most important risk factors for these endpoints and is a direct rationale for why antiviral therapy with virologic suppression has the potential to reduce the risks of these endpoints. This is a classic study that many of you who are clinicians are very familiar with, which is a REVEAL study from Taiwan, which looked at the incremental risk of cirrhosis in green and liver cancer in red with increasing viral load or HBV DNA, where there's a stepwise increase as the viral load goes higher. We have many other data points, which I won't include today, that look at the absolute risk threshold at different cutoffs of DNA that basically share the same story, both in Taiwanese population, but in other geographical cohorts as well. So I'm going to transition to what we do once we have established a diagnosis of hepatitis B on the basis of a positive hepatitis B surface antigen and or HBV DNA. We always start with a good history exam, starting with a family history. And I want to highlight this because I think that we often just ask about the patient, but asking about their family, whether they have any siblings, parents, uncles, aunts, grandparents with hepatitis B, but as well as that of liver cancer, because this is going to be a really important consideration, both for the choice of when you would treat that patient, but also regards to informing liver cancer surveillance. You always want to ask about medications and supplements. I always ask about prescribed medications, which are in our electronic health record. But unless you ask patients about supplements, they may or may not volunteer that as being clinically important. And because a lot of our patients are from cultural origins where supplement use is very commonly done, it's particularly important that we ask those questions, both for potential efficacy and potential safety concerns with the liver. Alcohol, tobacco, we'll come back to. In terms of laboratory tests, I think that we use the common tests, CBC with platelet count being a poor man's liver function test. Clinicians are very familiar with the concept that as the liver disease progresses, platelet count goes down. So if the platelet count goes down to less than 150, we're already suspecting advanced liver disease. If it's less than 100, we are already suspecting at least cirrhosis potentially, barring other etiologies. ALT is the most liver-specific liver enzyme that we use in clinical practice and is a good marker for disease inflammation. And prothrombin time is a marker of coagulation or clotting that reflects the ability of the liver to produce these markers, and therefore is used as a good measure for the function of the liver. The serologies are another topic which we can go into greater detail at another time, but in general, you want to characterize what stage or phase of infection a patient is in, which we won't go into detail today. But the E antigen is a very good marker for telling you whether someone has a recent infection versus someone who's had infection for a longer duration of time, and may help to identify the phase infection that patient is in, that in turn guides the approach to management. DNA is both important for confirming the infection, but also for the disease activity, as highlighted earlier, and is a direct component of who required antiviral therapy. Although this is a bit beyond what is required based on AASLD guidelines, my own clinical practice is to screen for HIV, hepatitis A antibody to assess whether immune, hepatitis C antibody, which is actually recommended for all adults 18 or older, and hepatitis delta antibody, looking for a rare co-infection of hepatitis B seen in approximately 5% of patients, but remains underdiagnosed. Of course, if they are not already immune for hepatitis A, vaccination should be offered. Now, I think although hepatitis A, hep C, and HIV testing is pretty commonly performed, hepatitis delta, I must highlight, is not yet formally recommended by the AASLD. It is recommended by the European and Asian Pacific societies, but I would be curious to see what my own colleagues on this call also share in this practice of universal delta testing. Now I want to also highlight that vaccination is an important component of our role as clinicians, and to vaccinate partners and household contacts, making sure that as we've already done a good family history, and by the way, I'd say at least 1/3 of the patients where I query families, there'll be at least one family member identified with hepatitis B and or liver cancer, and this should really help to guide approach to vaccination as well as management. And furthermore, all of these patients do require liver cancer screening. Now, the per AASLD guidelines, which were updated in 2018, any patient with hepatitis B should be offered liver cancer screening with ultrasound, with or without serum AFP, if they meet the following criteria. Anyone with cirrhosis, Asian or Black males age 40 or older, Asian females age 50 or older, family history of liver cancer, or hepatitis delta co-infection. Now, this is a little bit different than the Asian Pacific guidelines and other guidelines in the past, which made a distinction of Blacks, males or females starting at age 20. I, again, will be curious to hear about from my colleagues. I'll tell you that my own clinical practice is I offer liver cancer screening for all patients with hepatitis B at the time of diagnosis, at least annually, and increase the frequency to twice annually at these age cutoffs as defined above. And largely because I have continued to diagnose liver cancer in patients who never met criteria for that type of screening. And I think that's something where clinical judgment is needed for your individual patient. And then finally, staging of liver disease is an important step that we should take as clinicians. While the liver biopsy remains the gold standard, at least on paper, I think we all generally will use non-invasive testing that are familiar to many of you here in terms of serum indices like FIB4, serum fibrosis assays found in your local laboratory, FibroSure, FibroTest, HepaScore, ELF score, etc. And then liver elastography, either with FibroScan, ShareWave elastography, MRE, or other elastography tools. So the treatment criteria for hepatitis B today, I think it remains one of complexity. In fact, there are at least 8 different documents out there reflecting the fact that clinicians and hepatologists can't universally agree on the thresholds that should be used to govern antiviral treatment initiation. However, the domains in which we work are the same, which are E antigen status, positive or negative, the DNA cutoff, whether it's 2,000 or 20,000, and the ALT cutoff, whether it's any elevation above normal or 2 times normal, and how you define what normal is. And in general, I think that most clinicians who are specialists would agree that we don't use a laboratory reference range. Our local lab has an upper cutoff of 69 units per liter, which is ridiculously high in my view. And that's why using standardized cutoffs is what is adopted by most specialists today. And the most commonly used is the AASLD cutoff of 35 in men and 25 in women. And so I won't endorse any one guideline here, but these are the thresholds that are used. I think that there is strong advocacy, as alluded to by my colleague, Dr. Gish, that there really should be a simplification to how we approach treatment, that anyone who's viremic should be considered a potential candidate for antiviral therapy, taking into consideration individual characteristics. So I'll leave that at that for now. These are the drugs that are available in 2023. The 3 that are highlighted in red are those that are commercially licensed and first-line recommended therapies per AASLD guidelines. Peg interferon, of course, a weekly injection for 1 year is rarely used today. Entecavir and tenofovir are oral nukes or nucleoside-nucleotide analogs, or 1 pill daily, which represent the mainstay for first-line therapy today. I won't go into too much detail here, but to highlight that the success rate of suppressing HBV DNA is extraordinarily high. Within the first year, about 2/3 to 3/4 of E-positive patients will be undetectable, and approximately 90% of patients of E-negative patients will be undetectable within the first year. But mind you that this is not really the end goal of speed of trying to bring down the virus level within the first year, but long-term, there's robust data and long-term cohort studies which confirm that the success rate of entecavir and tenofovir with long-term suppression is extraordinarily good, especially if you are 3 years, 5 years, and beyond. E-antigen seroconversion is a notable goal, but is achieved in only about 20% of patients within the first year, and probably about 40% at 5 years. And then finally, S-antigen loss, the holy grail of functional cure, is an elusive goal that occurs in a very small proportion of patients with oral nukes, and also a larger but small overall likelihood of functional cure with peg interferon. I'll just close very briefly with a couple of concepts. One related to the impact of antiviral therapy, and number 2, comorbidities. So antiviral therapy clearly has clinical benefit. It is associated with decreasing disease progression rate with oral nukes. We have evidence that it can actually not only halt fibrosis progression, but can actually lead to regression of fibrosis over time. Even among patients with cirrhosis, 3/4 of patients after 5 years of antiviral therapy achieved reversal of fibrosis to a lesser stage of fibrosis, which is truly striking. And furthermore, we have robust evidence that antiviral therapy may decrease the risk of liver cancer, both in cirrhotic and non-cirrhotic individuals. And finally, hepatitis B therapy is associated with an improvement in transplant-free survival among patients with advanced liver cirrhosis with liver decompensation. So the idea here is that we have robust evidence that antiviral therapy, even despite its limitations as a long-term therapy, is highly effective clinically, improving clinical outcomes. So where we are in 2023 is that we have very good, safe, tolerable oral nukes, which can achieve long-term suppression, but is not curative. We can improve, although not completely avoid, liver outcomes. And there are ongoing challenges with special populations, including those in pregnant women, those undergoing mixed drug therapy in the post-transplant context. We're going to touch very briefly on management comorbidities in just a couple slides. And then the question, given the success of our current therapies, do we actually need additional therapies? Will functional cure meaningfully improve clinical outcomes beyond what we can already achieve? And what I would say, of course, is that the answer is yes, we do need additional therapies. There's great excitement for novel investigational agents that can really push the envelope towards a true functional cure. Sterilizing cure may be elusive in the short term, but functional cure I view as being achievable. And I think that's one thing that I'm sure Dr. Gish would love to share from our recent ASLD and APOSL meeting are some of the key advances looking at novel agents across mechanisms, which have already now demonstrated proof of principle that functional cure can be achieved. And then final concept I want to address are comorbidities. I have a whole content here that I can go through, but at the initial time, I'm going to take just 1 minute to discuss some of these comorbidities here. For those with HIV co-infection, it is clear that all HIV-infected individuals should be treated with antiretrovirals, which can overlap in terms of coverage of HBV. And therefore, all patients with co-infection should be treated with the antiviral regimen that also covers HBV. Hepatitis C co-infection is something that is a unique context where there is a very small risk of reactivation of hepatitis B, and therefore all patients undergoing hep C DA therapy should be screened for hepatitis B, including surface antigen core antibody and surface antibody, and so you can establish their status and offer immunization if not already immune. And then those with co-infection with Delta, those patients often require antiviral therapy for the hepatitis B and Delta, with Delta specific antivirals, particularly for any patient with elevated or positive viremia and abnormal liver enzymes. Metabolic conditions are very common in patients with chronic hepatitis B. And although I would love to be able to share more about the epidemiology and management strategies, the basic principle is straightforward. You should actively treat the coexisting diabetes and dyslipidemia in patients with hepatitis B and address weight loss due to the coexisting risk of fatty liver as a contributor to liver injury. Both alcohol and tobacco are common things that patients with hepatitis B consume, and obviously there's robust data that abstinence from alcohol is helpful for liver outcomes, and tobacco cessation can be useful for decreasing risk of liver cancer. Renal disorders are common among patients with chronic hepatitis B, often driven by coexisting diabetes, but other chronic kidney diseases. Be aware that both entecavir and tenofovir can be safely administered in patients with renal disease, but in the case of entecavir with renal dosing, is not modification not required for TAC down to a very low GFR. And finally, bone mineral density decline is common in the general population of those with chronic liver disease, including hepatitis B, and therefore consideration may be given in at-risk individuals for baseline testing of bone mineral density. And again, entecavir tenofovir should be administered for hepatitis B infected individuals in this context with appropriate monitoring. And so finally, the targets for antiviral therapy, I'll skip in this short time, but there's just such excitement for specific classes of RNA interference with ASOs and RNA interference mechanisms, immunomodulators, as antigen lowering therapies that we believe collectively may move the needle towards cure. I'll go ahead and stop in short time, but I'd be thrilled to address any questions and move on to our case discussion. Thanks so much.
Thank you so much, Dr. Lim. That was a really nice overview for hepatitis management considerations. Wanted to see if there's any questions and also additional thoughts from our experts. Dr. Finkel, I know you mentioned something in the chat if you wanted to maybe mention that out loud.
Sure, and thanks, Dr. Lim, so much for that talk, and thanks again for participating today. I just threw into the chat in kind of response to some of the queries that you had mentioned during the talk, and similar to you, I also do annual imaging on these patients, and when they turn 40 or 50, then switch it to every 6 months. And then also, I've also had some issues getting D-screening up on track, just like some other people were mentioning in the chat. And then part of that is in our region, a lot of patients are capitated to LabCorp, which we still have trouble getting. So we can get it through Quest, but most patients can't go to Quest for their testing here. So that's the challenge.
Definitely. Yeah. And we also learned that the IGER voucher for Delta testing is no longer active. So hopefully maybe that's something they will implement again, but I know that was an additional resource that was very helpful for folks. But hopefully LabCorp will also be on board with Delta testing soon. I don't have an exact date for that. I don't know, Dr. Gish, if you have an idea of when they're anticipating launching that.
I don't, but I'm going to bug them today.
Perfect. Perfect. And I saw you were also messaging in the chat. Any additional thoughts on Dr. Lim's presentation or queries or comments?
I think it's really good. I mean, he was talking about this structure and then where things are moving. And we have to remember these guidelines are 5 years old, with most of the data being 7 to 10 to 15 years old. The guidelines really need to keep up with the current information. So I think they're out of date in many ways. And we're supposed to be evidence-based, and people keep saying we need more research, but that statement sounds rhetorical and actually becomes a barrier to implementing the information that we have today. And we have data that over the last 20 years, we've had 5 guidelines from the AASLD, 4 or 5 from EASL, 3 or 4 from APASL, and the death rate from hepatitis B has not changed in 20 years. Yet we have very effective therapies, which are actually, in many settings, very inexpensive. Even in the US, I bought a year's supply of entecavir a couple of months ago for one of my patients, cash at $95 for 365 pills. That's at the FQHC cost level. So we have data that we can change outcomes, and it's going to be really a simple HIV, we treat everybody. Hepatitis C, we treat everybody. Why are we so complicated with hepatitis B? And the guidelines do not take into account stigma, discrimination, infectivity, extrahepatic manifestations, quality of life. The guidelines are just running off ALT and DNA numbers. They're really out of date. So I'm happy to hear they're going to be rewritten, and we're going to have a lot of input on that as KOLs.
Dr. Lim, any thoughts or reflections from those comments?
Yeah, absolutely. Well, two thoughts. One is just going back to the screening component. Obviously, the CDC's recommendation for universal screening is long overdue and very much welcomed. I'm not sure when that's going to be codified, but I know that hopefully that's going to be published momentarily.
6 weeks. It'll be out in 6 weeks, Joe.
Fantastic. Really looking forward to that. Obviously, we recognize that CDC recommendations doesn't automatically equate that all of a sudden everyone's going to be screened. There's going to be a lot of hard work by many of us to continue to advocate for application of those guidelines by payers within electronic health records, by population health groups within health systems to actually affect change. But that's just part of the battle, of course, of the screening. But I could not agree more with my colleague, with Bob. I've obviously trying to really simplify management is critically important. The complexity of our current model, I think, is really outdated. And of course, this should be supported by evidence. And I agree. I think there's going to be opportunity with the next guidance panel to really make meaningful change.
Great. I actually have a date for the CDC screening update, and I believe it will be March 16th, so a little bit sooner than 6 weeks. So, and we'll be sure to share that document with all of you, and we'll highlight that on our next ECHO, since that will follow after the guidelines have been released.